Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. Our next case is a 47-year-old female who presents with stage 2 ER/PR positive, HER2 negative left infiltrating ductal carcinoma, who's also had a lumpectomy. And the question again is adjuvant treatment. Did she warrant chemotherapy? So her history dates back to a routine mammogram identifying a left breast mass, no family history or other history of cancer. Mammogram showed a 1.6 centimeter spiculated mass at 12:30 to 1 o'clock. This was confirmed by MRI scan, which showed a 1.5 centimeter lobular enhancing mass containing a central biopsy clip of the known malignancy. Dr. Butler, do you care to comment on this image?
Sure. The image on the left is a computer-aided diagnosis colorized image. And although this is not 100%, the trend is that blue by convention colorizes areas that are mostly benign, and red by convention colorizes areas that are characterized by what we call washout kinetics. These types of washout kinetics tend to be associated with invasive cancers. The intermediate yellow colorization is called plateau kinetics, and it can be associated with both benign and malignant tumors. And here we see that that is the predominant type of kinetic behavior, although there are some areas within it that are red, indicating washout, that make it more suspicious. And in the image to the right, we have a sagittal image that shows this enhancing mass with a signal void that represents the biopsy clip placed after the imaging guided biopsy.
Thank you, Dr. Butler. Again, her biopsy revealed an invasive ductal carcinoma, grade 2, ER/PR positive, HER2 negative, and her recurrence score was 22. She had a left lumpectomy, negative surgical margin, grade 2, 1.6 centimeters in dimension. She had 2 out of the 3 sentinel lymph nodes returned positive, and we wanted to discuss what would be the next optimal treatment for her. Let's start first, I guess, with Dr. Mamounis. Do you feel with her 2 positive lymph nodes that, again, any additional axillary surgery would be warranted?
Yeah, again, this is also a patient, as we discussed previously, that technically fits into the Z11 category, and she could have participated in that study. I will look obviously carefully at the metastasis in the lymph nodes. Is there any extracapsular extension, the size of the metastasis? But I would not feel uncomfortable if she chose, and we recommend no additional axillary surgery. And obviously be interested to hear Dr. Shaw's comments in terms of, again, treating this as a Z11 or versus the AMAROS trial. But I think I would be okay with not completing the axillary dissection for this patient.
Dr. Shaw, I assume if you were treating the regional lymph nodes with one one positive lymph node, that two positive lymph nodes would be consistent with that? What would be your recommended treatment?
Yeah, I would say with two positive lymph nodes after sentinel, my preferred technique would be to cover the breast, the full axilla, the supraclav, and the internal mammary nodes as well. And typically in 50 gray and 25 fractions. I would worry in someone who's 47 and has two nodes, and would err on the side of treating comprehensively.
Very good. And then Dr. O'Shaughnessy, this is a couple interesting questions here. With her younger age and two positive lymph nodes, do you feel any role for adjuvant chemotherapy? And is there any role for CDK4 inhibitors in the non-metastatic setting eventually as a component of approach to endocrine treatment in the adjuvant setting?
So this patient is 47, but she has had a previous BSO. So she is postmenopausal. And in the RxPonder trial that randomized patients with a recurrence score of 25 and under to endocrine therapy alone versus endocrine therapy plus chemotherapy, the postmenopausal patients had no benefit from chemotherapy whatsoever. So I would not recommend chemotherapy to this patient. And so, but I would recommend an aromatase inhibitor to her for 10 years and then IV zoledronic acid for 3 to 5 years as a standard of care. With regard to whether she would benefit from abemaciclib, adjuvant abemaciclib as per the Monarch E trial, that trial enrolled very, very high risk patients, either 4 or more nodes. If 1 to 3 nodes, they had to either be grade 3 or T3 breast cancer, which she was not. There was a cohort if the Ki-67 was above 20%. So we don't know that about this patient. But my general feeling about the use of abemaciclib right now is that it's too soon. We need longer follow-up on Monarch E right now at about 19 months median follow-up. There's about a 3.5, 3.9% improvement in invasive disease-free survival, but only 50% of patients have stopped their 2 years of abemaciclib. So I just think we need longer follow-up to see, whether there's a sustained improvement in invasive disease-free survival with the abemaciclib. We saw at San Antonio in the Penelope B trial in a high-risk population that had residual disease after preoperative chemotherapy, again, ER-positive patients who took 1 year of palbociclib versus not, that the curves split while the patients were on palbociclib in terms of improved invasive disease-free survival. And then there was also a benefit for a while after patients stopped the palbociclib for a year or so, but then the curves came back together again. So I think we have to wait for more data from the Monarch E trial before utilizing abemaciclib, as a standard, or even for higher risk patients.
Thank you. Back to the question concerning chemotherapy. Sometimes 35-year-olds who have their ovaries removed for benign conditions, they might be put on estrogen replacement therapy. And it's challenging to determine, is this then a premenopausal situation or postmenopausal situation, or how are kind of your thoughts about artificial estrogens?
That's a really interesting question. I haven't really come across that specifically, but I think that I'd probably think of that woman more like a premenopausal patient. Certainly the cancer would have been born into a more premenopausal estrogen milieu. Of course, the estrogen will be stopped immediately upon diagnosis, and then she'll be postmenopausal, and that's a very profound endocrine therapy, if you will, is stopping the estrogen receptor. Stopping the estrogen, and really, so the question is whether it's the chemotherapy again with just ovarian suppression from the chemotherapy, or is there a more of a direct cytotoxic effect of the chemotherapy that's more profound in the premenopausal population? I think we don't know the answer, but I'd probably err on the side of considering her a premenopausal patient.
Thank you very much. Very interesting case.